Project Echo headquarters in New Mexico that we're using their platform, the Echo platform, as well as our partners on the ground in East Africa in particular through our Safe Surgery program in Ethiopia and Tanzania. I'll pass it along to my colleague Vaughn to get us started on the presentation.
Hi everyone. I just want to take a few minutes to discuss some points on etiquette. We'd like to remind you that Echo platform is founded on respect, and we rely on you guys to keep it a safe and collegial space for learning. Please make sure to test your equipment ahead of time to ensure your audio and video are working. This minimizes distractions. If you have a question, there are two options. You can either write your question in the chat box located at the bottom right-hand portion of your screen throughout the course of the meeting, or you can wait until the end where we'll have a Q&A session where you can use the raise hand function, which is located under the participants button at your bottom toolbar, and the moderator will call on you to ask your question. Please mute your microphone when you're not speaking. The mute button is located at the left bottom corner of your screen, but then remember to unmute before you're called upon to speak. We ask that if it's feasible, you turn on your webcam and position it optimally to show your face or to capture the whole group you're with, preferably with the light source in front. We value the communal nature of these meetings and think seeing your face enhances this experience. When you speak, please do so close to the microphone for optimal audio. And finally, if you have any IT issues, just send a message through the chat function or via email. Now I'd like to introduce our first speaker, Dr. Bridget Hurry.
Hello, and wonderful to see you all here today. I'm going to present thank you, Vaughn. And as she mentioned, my name is Dr. Bridget Hurry, and I'm here today with a colleague, Dr. Hay. Today we're excited to share what we can collaborate to improve our global care for COVID-19 patients. And by the end of our session today, I hope that we will all appreciate a heightened ability to detect and manage hypoxemia, to improve the delivery and monitoring of our patients receiving oxygen therapy, and to use these skills to better improve our overall care for COVID-19 patients. As you'll recall from our session number 1, COVID-19 is a respiratory illness. 81% of COVID-19 positive patients will present with mild illness, which would clinically present as a fever, sore throat, or cough. 14% will present with severe disease, which is clinically seen as pneumonia. 5% can manifest their infection with, which we call the disease process SARS-CoV-2 as acute respiratory distress syndrome, septic shock, or multi-organ failure. And there also has been a subset of about 1% of patients presenting with an asymptomatic form of presentation. This slide just depicts the WHO definitions for severe and critical disease, including severe pneumonia with a clinical significance of having an oxygen saturation, or SpO2, less than 90%, and ARDS, which is a more extreme form of respiratory compromise, which the acronym represents acute respiratory distress syndrome. To begin, we must remind ourselves of the definition for hypoxemia. Hypoxemia is an insufficient delivery of oxygen in the blood. The WHO defines this as a SpO2 less than 90th percentile. We see this clinically in our COVID positive patients in conditions such as pneumonia, ARDS, sepsis, and shock. We can draw upon our experience with hypoxemia as seen in previous conditions such as malaria, trauma, surgery, or obstetrical complications. There is a myriad of clinical presentations for patients with hypoxemia, but these clinical findings include cough, shortness of breath, elevated heart rate or respiratory rate, fatigue, a use of recruiting accessory muscles, or confusion. In order to avert the associated complications with hypoxemia, it is imperative that we have early detection and early implementation or the initiation of oxygen therapy. There are two chief modalities to detect hypoxemia. Those are pulse oximetry, which detects the SpO2, or an arterial blood gas. A pulse oximeter is a machine that measures oxygen saturation in the blood. It is non-invasive and accurate. It transmits a light beam through a distal digit, such as a finger, toe, or even earlobe, and it is able to measure the SaO2, or the arterial oxygen saturation. In the clinical scenario for our COVID positive patients, it is imperative that we use a modality to measure the SpO2 for all patients with COVID positive complications. Oxygen therapy, again, is being used to alleviate hypoxemia, and it can be indicated in patients with complications such as cardiovascular arrest, elevated heart rate, which we define as greater than 24 breaths per minute, hypoxia, which could include a saturation of oxygen less than 93%, hypotension, or metabolic acidosis with a low cardiac output. Our goals for oxygen therapy are an SpO2 of greater than 90 percentile in non-pregnant adults, 92 percentile in pregnant adults, patients, a normal respiratory rate, which we define as anything within a normal range, less than 24 breaths per minute, and a normal respiratory effort without the recruitment of accessory respiratory muscles. After the detection of hypoxemia, it is imperative that we administer oxygen therapy. Oxygen should be seen as an essential medical drug, and as with the prescription of any drug, our prescription must include the flow rate, the delivery system, the frequency and modality of desired monitoring, parameters for what to report for oxygen response, when to change the device, and when to wean or terminate the use of oxygen therapy. For oxygen flows up to 5 liters per minute, we can use a nasal cannula for our delivery system. For an increased flow of 10 to 20 liters per minute, a face mask or bag valve mask may be used, and that includes a simple mask, partial rebreathing mask, or non-rebreathing mask, or ambu bag. Non-invasive ventilation, which includes CPAP or BiPAP, can increase our oxygen delivery up to a flow of 60 liters per minute. It is imperative in our COVID positive patients that healthcare workers implement airborne transmission precautions before the delivery of non-invasive ventilation, as this does increase the risk of aerosolization. And lastly, mechanical ventilation or invasive ventilation is the last form of oxygen delivery availabilities. For patients requiring mechanical ventilation or invasive ventilation, healthcare workers must recognize that the initiation of this ventilation has to be used with airborne transmission precautions in place as well. We recommend and have seen for COVID positive patients, we should pre-oxygenate with 100% FiO2 maintained for 5 minutes, and that can be achieved via face mask or bivalve mask prior to the intubation process. And mechanical ventilation does require an endotracheal tube or tracheostomy. This slide is representing a spectrum of recommendations for the management of COVID positive patients, ranging from mild disease patients with mild ARDS up to moderate to severe patients. And then it's also offering some rescue or adjunct therapy recommendations. What is imperative about this slide is we can see the target is a SpO2 of 92 to 96 percentile. Some patients will require lower oxygen therapies with a goal always being maintained above an SpO2 of 90 percentile. We notice that when ventilating our patients, for COVID-19 ARDS patients, a higher PEEP has been seen and recommended. And we have also noticed that prone positioning for our patients that are ventilated is recommended for 12 to 16 hours. And that is also listed here as an adjunct or rescue therapy. And I'll touch on that in the next slide. Other considerations that we must keep in mind with our COVID-19 population is that we must always maintain a high suspicion for rapid deterioration. With that in mind, we must be mindful that the putting on of PPE gear or the donning of our gear can take 5 to 7 minutes. We also must always have our healthcare facilities well equipped with rapid sequence intubation kits and checklists. As previously mentioned, for ventilated patients, there was a study published in the New England Journal of Medicine in 2013 out of France that noticed an improvement in VQ matching for when patients were placed in a prone presentation or prone positioning, that is the patient on their abdomen, while mechanically ventilated. We know this can shift the weight of the lungs and edema, and it can recruit more of the dorsal alveoli. We have seen in early studies with COVID positive patients that the use of proning is also helpful in mild COVID positive patients, even prior to mechanical ventilation, and has been able to avoid some patients from needing mechanical ventilation. Proning in non-ventilated patients should initiate for 1 hour, but should be encouraged to maintain that position as long as they can tolerate it. That is the overview for our oxygen therapy, for our detection and management of hypoxemia, as well as the delivery of oxygen therapy and how we can implement that to better serve and care for our global COVID-19 pandemic. I'd like to touch on just a few questions that were brought with the session number one. One question that we received was, how can we adapt our health systems to ensure continued access to essential services such as childcare health or HIV during the COVID pandemic? We have seen the ability to maintain continued access for essential services by the use of cohorting or grouping of our COVID positive population. One avenue for this is to cohort or group our COVID positive patients in retrofitted community facilities such as hotels or churches or boarding schools. This allows for our healthcare facilities to still remain accessible and free to continue with our essential services outside of the COVID positive patient care. Based on your specific country's strategy, this cohorting can be reversed. Our COVID positive patients can be cohorted or grouped in the medical healthcare facilities, and our community facilities can be retrofitted to deliver essential services such as maternal child health or HIV services. What are the effects of COVID-19 on pregnancy? Overall, the management for COVID positive pregnant patients is essentially the same as that for non-pregnant patients. We are seeing with our outbreak here in New York, USA, that a significant portion of COVID positive pregnant patients are presenting asymptomatically with rapid deterioration in the course of their labor or postpartum interval. And so again, it is imperative we are mindful and expectant of a rapid deterioration situation. We have not definitively found virus being transmitted through an intrauterine transmission out of one study that had over 38 COVID positive pregnant women. We have not found the virus detected, excuse me, in vaginal secretions, amniotic fluid, or breast milk. The risk in breastfeeding, however, is concerning in a COVID positive pregnant or mother, as there is a risk of droplet transmission to the close proximity to a newborn infant. And it is recommended the postpartum pain management agent of choice is acetaminophen or paracetamol, as there are some anecdotal cases of complications with non-steroidal agents. What are some community awareness strategies for protective measures against COVID-19? Again, the key for our ability to transect the disease course for COVID-19 pandemia is mass communication about hand hygiene, respiratory hygiene, and social distancing. In order to recruit community ownership, we will see that there will be more compliance with our strategies, so we can advocate for ownership through campaigns such as community making or the manufacturing of cloth masks to be used by the general public, where social distancing can be challenging. We can also use our community in different volunteer scenarios, such as manning telecommunication sites for triaging or delivering of mass community message systems. How can we strengthen our infection prevention and control, including PPE and healthcare capacity, in a sustainable way? The key to stewarding our global supply of personal protective equipment, or PPE, and our healthcare worker capacity is to minimize our unnecessary use of PPE and to minimize our healthcare worker exposure to COVID positive populations when not necessary. One opportunity to do this is to have a cohorted situation for COVID positive patients where PPE can be worn for a longer extension of time, or designate a subset of healthcare workers who can work on this cohorted or grouping of COVID positive patients that enables a decreased number of healthcare workers to interface with the COVID population. We could delay or cancel all non-essential procedures to have that resource of PPE available for the COVID pandemia. We can restrict non-essential healthcare workers' access to our PPE to our COVID positive population in order to save that PPE supply. How can we prepare for COVID in a resource poor situation? Again, we can educate our communities about the importance of hand hygiene, respiratory hygiene, and social distancing. We can ensure that at all healthcare touchpoints, we have prompt triage and subsequent isolation of any patient with a positive screen for COVID positive symptoms. Even in the scenario where COVID testing is not available, with isolation of a suspected patient, we can directly impact and decrease the transmission of our COVID positive suspicion. And lastly, is there any way to reuse PPE? WHO has offered some reprocessing modalities for our personal protective equipment, or PPE, but the emphasis is that this should be used as a temporary measure as the supply is limited, and all PPE should not be reused if it is noted to be soiled or damaged. Gowns, face shields or goggles, and eye shields can be reused for a longer period of time, and the extended use in the situation of a cohorted group of COVID positive patients is for a extended continuous use of up to 6 hours. Gloves should never be reused and should be changed from from care as you transition from one patient to a second, and should also be changed if there's been any contamination with bodily secretions. There are some efforts to clean or re-sterilize, reprocess the N95 respirators, and those processes are using things such as ultraviolet radiation, moist heat, or hydrogen peroxide vaporization. Thank you. I'll now introduce my colleague, Dr. Hay, for his opportunity to share lessons learned. Thank you.
And thank you, Bridget. That was great. Before we move on to Dr. Hay, I'm going to be sharing a poll with everybody. If you guys could just take a minute to fill that out so we can get some information from you, that would be great. And if you have any questions, please remember that you can ask them in the chat function, and we'll be getting to those in just a second. Is everybody able to see the poll?
Yes.
We'll be ending the poll in just about 1 more minute, so please finalize your answers. All right, thank you, everybody. At this point, I would like to turn it over to Dr. Hay to answer any of the questions that you guys might have. Dr. Hay, are you able to hear us?
Yes, I can hear you. I can hear you.
Excellent, thank you. Does
You
anybody
can
have
hear
any?
me?
Yes, we can hear you. Thank you. Does anybody have any questions for Dr. Hay? If not, we can start with some of the questions that were left unanswered last week. Well, Dr. Hay, while we wait for questions, would you mind just sharing your experience dealing with COVID in your hospital?
Okay. So firstly, because of this is a novel diseases, so most of the general persons they feel worried about this diseases, and so the most I think interest for me is that the clinical outpatients, the number of the clinical outpatients decreased predominantly significantly when the novel disease was identified. But what's I think it is
We seem to have lost you. Dr. Hay, are you there? I think we've lost
I'm
his
sorry, I
connection.
think there's something wrong. Okay.
Oh,
Now
excellent.
I'm back. Okay. I'm so sorry. So, in my opinion, the most of the children patients, the symptoms are mild or moderate. They're not so severe when compared with the adults or the elders. So, firstly, it is very important to provide accurate and scientific information to the public to avoid panic. And I will also share my 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 experience for the treatment of one patient from Hubei province. The suspicion of the COVID-19 was built because the child behaved with fever and cough, and so I completed the collection of the samples from the child, and I also called the X-ray doctors and lab investigators to come to my clinic to complete the necessary detection, and then the child was sent to the isolated bed. So I think a reasonable arrangement of the outpatients and of the ward bed for the new diseases is very important for every hospital to avoid hospital cluster infection, which is necessary from Wuhan to avoid the unnecessary consumption of the medical resources. Thank you.
Thank you, Dr. Hay. Let's go ahead and I've seen some questions coming in from the chat. Let's go ahead and start asking some of those. Monica?
Yep. Hi, everyone. So please keep sending your questions via the chat function. This is really helpful. And we'll start going through them. So I do want to note that most of these questions are both for Dr. Hay and Dr. Bridget. please feel free to answer them unless I specify if it's for one or the other of you. So the first question is coming in from Nigeria. What are the effects of COVID-19 on asthma and chronic obstructive pulmonary disease? Is the management protocol different? Maybe Dr. Hay, we'll start with you.
Sorry, I can't catch you. May I beg your pardon, please?
Yes,
Okay.
of course. I'll
Maybe,
repeat the question.
Okay.
Yes, I'll repeat the question. What are the effects of COVID-19 on asthma and chronic obstructive pulmonary disease? Is the management protocol different?
Okay. I think that's the management of the COVID-19. Maybe it is different from SARS. It is similar with SARS, but also similar with most virus pneumonia. I think in children, the only difference is about the isolation. The isolation protocol for the COVID-19 patient. I mean in children, because I'm a pediatric doctor. I think in children with COVID-19, the isolation protocol would be compulsory, would be more effective than the other common diseases. And the another difference of the this novel coronavirus, I think is that the mortality or the case fatality is much lower than SARS or MERS, and so the infectious ability of this disease is much more stronger than I think than the MERS or SARS. So under the bronchial dilators, it's I think it's a symptom control treatment. I think all the symptom control treatment is effective or is useful if the patient had a symptom. But until now, I think no effective antiviral drugs were identified, although there are some clinical trials carried out to test whether some drugs, are really helpful or specific useful for this new diseases. Thank you.
Great, thank you. Dr. Bridget, do you have any comments to that, or I'll move on to the next question?
I just, to complement what my colleague Dr. Hay was sharing, I think it's important that we recognize that patients with asthma or COPD are in our subpopulation of patients that have a pre-existing comorbidity. So the management of these patients will be more intensive as they are more susceptible to severe or critical disease complications. The management of COVID positive patients is largely recommending to not use steroids due to possibility of prolonging the viral activity. However, in this subset of patients with asthma or COPD, there are clinical indications for the use of steroids to help treat and manage these significant comorbidities. So I think that's the key difference that we are seeing for this subset of COVID positive patients with the comorbidities of asthma or COPD.
Great.
Thank you,
Dr. Bridget.
Oh, sorry, Monica. I've got another question that came in for Dr. Hay. Dr. Hay, have you been seeing any cases of reinfection in China?
Yes, there are some cases about the reinfect, but it is really difficult to identify whether these patients are real reinfect, because some patients, the detection of the virus they tested negative, and then we send the patient to their own home, and then after maybe 1 week, the RNA detection showed positive. So we call this patient maybe reinfect, but we don't know, because the sensitivity of the detection kit is not high, maybe 13 to 14% in China for the detection kit. So it's very difficult for us to evaluate whether there is something wrong in the detection kit, or it's a real reinfect patient one. But I think although we have watched some cases with this similar reinfect phenomenon, but this is really rare. I think really rare.
Thank you.
So can you get me?
Yes, thank you.
Thank you very much. Dr. Hui, another question coming in. What is the importance of oxygen therapy in resource-limited settings with limited access to ventilators? And I guess, how do you address the issue of lack of ventilators? What are other alternatives?
It's a great question.
Okay.
I think in the scenario where we have limited access to mechanical ventilation, the initial presentation of COVID positive patients will require our triaging, prompt triaging and isolation. And then initially we will offer a palliative therapy, such as, for the symptoms of cough, fever, sore throat. As respiratory distress and hypoxemia develop, we must just manage our clinical complications with the available oxygen therapy delivery systems, nasal cannula and face masks being ideal, for there's no additional aerosolization risk. There are going to be numerous patients that are in need of increased oxygen flow. And this is where initially I would recommend we try putting our COVID positive patients in a prone position for as long as they can tolerate. We have seen this increase our VQ matching and allow for some patients to not need the requirement for mechanical ventilation. And as the deterioration of a respiratory status is seen, if non-invasive ventilation is available, like CPAP or BiPAP, that is a modality that we could consider. But again, we must be very careful for our healthcare workers to use aerosolization, transmission prophylaxis for this additional risk for the high flow of these non-ventilation modalities. Thank you.
Thank you. And again, a little bit following on that a little bit with regards to ventilators, what is the role of ventilators in severely ill COVID-19 patients in the ICU and the role of corticosteroid? And that's to either Dr. Hui or Dr. Hay.
I think the role for mechanical ventilation. Go ahead,
so
please.
It's about the.
Dr. Hay, why don't you start?
So it's about okay. So it's about the use of mechanical ventilator and steroid drugs. I think the mechanical ventilator is very useful and important for the critical ill patients. But what we need to evaluate is whether the hospitals or the local government can provide the enough mechanical ventilators to all the severe patients. And so if there is a question is that like in the early stage of the outbreak of the diseases in Wuhan, you know, the mechanical ventilators is not enough. So the policy for our country, for our government is that to collect the mechanical ventilators from other regions to support Wuhan. So firstly, if there are many severe or critically ill patients in a local area, the country should collect the machine to support the local area, like New York in United States. The second question is about the it's about the use of the steroids. I think it should be careful because we have the evidence that maybe the virus can attack the immune system directly. We found some severe patients with less CD4 behaved with low CD4 T cells, CD8 T cells, and B cells. Up to now, we don't know whether this phenomenon is just a result of the direct attack by the virus or the exhaustion of the immune cells to combat with the virus. But there, I think one research have found that the marker of the CD114.7, which can be the route for the virus to directly attack the T cells or B cells. So the large dose of the steroids will be carefully considered. However, the low dose of the steroids were identified to be useful in some patients because it have the function to suppress the cytokine store. So there need to be more clinical trials to dig out whether steroids or how much of the dose of the steroids should be used in COVID-19 patients. Thank you.
Great, thank you. I'll move on to the next set of questions, two here relating to HIV. Dr. Hurry, I'll pass this along to you. Does HIV infection appear to be protective of critical condition in COVID-19 due to ART use? And then I'll add on a second question if that's okay. How do we differentiate between PCP and COVID-19 in an HIV patient because they both have similar presentation?
Yes, thank you, Monica. Those are great questions. And you might notice I answered some of the other questions on the chat function as these are two tricky questions. So the use of antiretrovirals for the treatment or adjunct therapy for COVID positive patients is still under investigation. I am limited in knowing if there have been some studies to show significant clinical success. Obviously, we must recognize that in our HIV population, they are at risk for severe or critical COVID positive disease because that is a immunocompromising condition. I'm just getting a little assistance from a friend I'm seeing here. Okay. So it's possible, what do we say? Well, I'll answer the other question and I'll be able to review this. Oh, PCP pneumonia. That's another good question. Radiographically, they're gonna visualize very similarly with the ground glass opacities and the productive cough. I think our clinical suspicion with an HIV positive patient should include the possible co-infection with PCP, and then if there is not a clinical response to the routine care of the patient with a PCP pneumonia, we can then advocate for a suspicion that there's a additional infection with the COVID virus. Ultimately, the COVID situation would lead to more respiratory distress without response for these PCP potential patients as well. I'm gonna I have a study that someone shared about the use with antiretrovirals. So let me review that and I'll share while Dr. Hay, if you have any other opportunities to share. I just have limited understanding if we've had clinical statistical significance yet with that subpopulation.
So yes, I'm sorry, I don't have any experience on the for these patients for this diseases occurred in HIV patients. I have little knowledge about this condition. I'm so sorry.
That's okay. We're asking we're getting a wide range of questions here, and if we can't answer them on this chat, then we're definitely going to do our best to address them later on. So that's okay. Let me ask another technical type question, then I'm going to move into a few questions regarding healthcare workers. Again, this is to Dr. Hurry or Dr. Hay if you have any knowledge on this. Is bronchodilators such as salbutamol, and apologies if I'm not saying that correctly, helpful in the management of COVID patients?
Okay, I know salbutamol, like the drugs of the bronchial dilators, like salbutamol. I think it's a symptom control. It's a symptom control treatment. As far as I know, we don't know whether the bronchodilators would have a useful effect to improve the long-term outcome of the COVID-19 patients, but maybe it may be useful for some severe patients to migrate the symptoms with short of breath. So this is my own opinion or my own experience for the bronchodilators. Thank you.
Thank you, Dr. Hay.
I think the only additional insight I would offer is that, again, due to the risk of aerosolization, we want to avoid any nebulizing treatments. And corticosteroids or steroid use, again, could promote by weakening one's immune system, it could promote viral, prolonging the viral existence in the patient. So we want to avoid the use of that.
Thank you. Bridget, I noticed that you've been responding in the chat. Thank you for that, regarding some kind of do-it-yourself or make-it-yourself masks. One question did come in regarding safe disposal of masks. Do you have any thoughts on that you could share?
That's a great question. So First, when we are removing our PPE or personal protective equipment, it is imperative that we avoid touching the potential contaminated surface of a face mask. So we would want to use our contact point as being the straps around the earlobes or the crown of the head. We recommend you have a designated container for the collection of contaminated face masks. And then there is the recommendation that container bag should then also be placed within a second bag to not allow for contamination for the handler of these contaminated masks. And there have been some efforts, as I previously mentioned, of reprocessing the masks, but right now that is to be used only with those who are very comfortable with these techniques, as they all do require some corrosive agents such as hydrogen peroxide vapors or ultraviolet radiation. And yeah, I did share in the chat box, there were some good questions about using face masks, homemade cloth face masks. The CDC has recommended that for the general population, they wear cloth face masks. Again, this is to prevent transmission where social distancing can be challenging. Also to avoid the potential for transmission among our asymptomatic subpopulation. The CDC has a resource that I posted the link here in the chat application, where you can go to receive direction on how to make the cloth face masks. It is imperative that we use frequent washing of these cloth masks, and it's recommended to be 60 to 90 degrees Celsius in heat when we're washing either reprocessed gowns, cloth gowns, or face masks. We also need to be careful with the handling of our cloth masks, where there could be a potential for contamination. So hand hygiene is very imperative before and after any handling of our cloth masks. And Alessandra had a very good question about, could this be used for healthcare workers? This is currently not the recommended mask for healthcare workers, because we do not know it's not a standardized filtration from one cloth mask to the next. But if it must be used, you want to use as many layers of fabric as possible. There are some situations where people are putting filters or older masks inside the layers of or paper towel or another layer of thickness within the inside of a cloth mask. But those should be saved for the general public so that we can resource medical quality masks for our healthcare workers.
Thank you. This is a question for Dr. Hay. This came in from our partners at Bugando Medical Center. What is the rate of COVID-19 infection among healthcare workers in the areas where you worked? And also, what are the current recommended and appropriate distance between people? Because we've all heard 2 meters, but I guess there is some suggested evidence that 2 meters may still allow some transmission.
So, okay. In our hospital and in our city, no medical staff or the healthcare workers infected with this COVID-19 in their work. But according to my knowledge, over 3,000 of the health workers in Hubei province, which is the city of Wuhan located in Hubei province, more than 3,000 of the healthcare workers, they are getting infected. And I think maybe about 40 to 50% of the 3,000 they are infected in the hospitals during their work. And however, after the change of the preventive protocol and the standard for the health workers in China, so then there's no health workers infected reported in China. I think maybe from February till now, no health workers get infected. And another question is about social distance. I think it's according to the condition. In my own opinion, that's my own opinion. I think the young patient, the young adults, they need to fear about these diseases, because I think the mortality for these diseases is really low in the young adults. But for the elder ones, the best way for them is to decrease the social activity and strictly keep the social distance from others if they have to take part in some social activities. This is my own opinion. Thank you.
Thank you, Dr. Hay.
Monica, I just wanted to circle back.
Sure.
Antiretroviral question. So there are two studies, both with a very small population, but one had some HIV positive patients in the same clinical healthcare ward as SARS patients, or at the COVID positive disease process for severe or critical COVID positive patients. And of these patients that were in the same ward, 11 of the patients with HIV positive condition were on antiretrovirals, and they did not convert with or have transmission of the SARS disease. So while our N, or our subpopulation for this these evaluations and studies is low, there is some promise that maybe the antiretrovirals has a protective effect. And there is a link that I just put on the chat about the COVID-19 HIV and antiretroviral potential protective effect. And thank you to Vaughn for that resource that she made available.
Thank you, Dr. Hurry. Another question for you with regards to the oxygen therapy. In resource poor settings, in the absence of oxygen, could an oxygen concentrator suffice? And if so, what percentage of oxygen can it deliver?
The key for oxygen therapy is to monitor our SpO2, so the percentage of the arterial oxygen concentration, and to maintain a SpO2 of 90 to 92%. In the absence of resources such as the goal is to avoid mechanical ventilation for the comorbidities of just being mechanically ventilated, but also to keep those ventilators available as there's a global strain on our supply. So to use any other modality to deliver our oxygen, the goal for how much to deliver, again, should be monitored, ideally with a pulse oximeter, as it is non-invasive. But ABG, arterial blood gas, is also available. But our goal is to just give enough oxygen, no more than what is required to achieve a SpO2 of 90% or higher. That said, it must be emphasized that the higher oxygen requirements, or the higher flow rates, are going to have an increased risk of aerosolization. And so the risk of transmission and potential we need our healthcare workers protected in the delivery of these higher flow rates to avoid airborne and aerosolization and airborne transmission.
Great. And another question about oxygen use. What about oxygen reuse and decontamination of equipment?
I don't know if I know what oxygen reuse means. Is it like the nasal cannulas, or I'm going to defer to Dr. Hay in case maybe he's understanding better than I am. Sorry.
So it's about the oxygenation reuse. I'm not so clear with the question.
Yeah, sorry, that's a question that came in during registration. So if we're not clear on it, whomever sent in that question during registration, if they want to type in more details into the chat box, that would be great for our doctors to understand a little bit better. At this time, maybe I will just open it up and see if anyone else has any questions they want to put in the chat box and or ask themselves. You're welcome to raise your hand and ask a question directly to Dr. Hay or Dr. Hurry.
And Monica, so the question that I saw from registration was for the reuse or decontamination of equipment. And I believe that was in regard to, so I think we can defer to the discussion we had on the decontamination and reprocessing of PPE.
Okay.
Any questions? Sorry, I apologize. I think I interrupted you, Nugesi.
Hello, my name is Nuguse Talawan and I'm a surgeon. Can I ask how can we use PP or which type of PP is more preventive COVID-19 in patients, in non-surgical patients which doesn't have surgical cases, for example, it's say some patients may undergo surgery for any disease, and how can we prevent in resource limited countries like us?
Thank you. I can share I initially heard what PPE or personal protective equipment is to be used. And I think, again, it is imperative that we do ask that question to ourselves and that we continually ensure that we are using the appropriate PPE to not misuse our limited resource. For any contact or care of a COVID positive patient, it is recommended that you have a gown, you have a face shield or goggles, but they must protect the sides of your face, gloves that overlap the wrists of your gown, and then a mask. And I think the key to your question is the N95 respirators are being recommended for use only when we are in a situation where clinically we could be exposed to aerosolized procedures such as intubation, other oxygen delivery procedures, but a routine medical face mask is the recommended form of mask for non-aerosolizing management of COVID positive patients. Dr. Hay, do you have something? Thank you for your question. And Dr. Hay, anything you'd like to add?
Yes. For the PPE, I agree with you that it should be used according to the condition. And another point is that the PPE also should be used according to the condition of the local government. How about the capacity of the produce ability for the PPE? Definitely, if the PPE is enough, so every doctor or health worker should wear the PPE. But if the PPE is not enough, my advice is that the PPE should be provided according to the risk of the exposure of the COVID-19. it should be provided to the doctors or nurses in most dangerous situation. Thank you.
Thank you. Are there any other questions from participants on the call right now? Okay. Well, if there are no other questions, I'm going to pass it over to my colleague Chase to close out.
Thanks, Monica. Thank you, Dr. Hurry and Dr. Hay. This was very informative, and I think we were able to answer a lot of people's questions. I'd like to thank the GE Foundation again for helping to make this possible, as well as our translator, Charles, for making it possible for those who want to listen in French to be able to participate in this. And then a big thank you to all of you for joining us, and we hope to see you guys next week.
Thank you.
Thank you.
Thank you.
Thank you. Thank you. Thank you. Thank you very much.
Thank you.